I think, happier that I was invited to speak than we were. Here are my disclosures. And this is my work home, as I lovingly call it, Wellstar Kennestone Regional Medical Center in Marietta, Georgia. It's a 633-bed hospital with an adult-only cardiac program that I'm personally very proud to be a part of. I work with a very progressive team of clinicians led by Dr. William Cooper, and I'm surrounded by a culture of mutual respect and one where we take patient care much more seriously than we take ourselves. So this culture is what has allowed us to develop this method. When I last spoke on this topic, first of all, my slides wouldn't work, so we're in good shape. Back then, we had 5 perfusionists, 3 cardiac surgeons, we covered 1 hospital and had 2 ORs. We now have a team of 8 perfusionists, 4 cardiac surgeons, we cover 4 ORs and 2 hospitals. We also kicked off our ECMO program last October with 18 ECMOs in the first 3 months. So this doesn't sound like any other growing program, with the exception of one thing, and that's the cardioplegia. Whoops, sorry about that. I can't see my mouse. So will this, sorry. I have a question you might have to come up here to see. Can I, oh, there we go. Got it. Thank you. Sure. As our center and our patient population was changing, our cardioplegia became the constant. As Al spoke of yesterday, different surgeons all give different kinds of cardioplegia. There are numerous numbers of formulas. By a show of hands, how many people here are Quest users already? I'm just curious. Thank you. At Wellstar, regardless of the hospital, the surgeon, or the procedure, we use a standard formula and dosing assessment for all patients. The cardioplegia is made in-house, and our patients are receiving an average of 57 cc's per case. The method is a modified all-blood single dose. Today, I'll walk you through our process and how it evolved. I will talk in depth about the method itself and how it has affected our practice. Lastly, what have we learned about this method? I'm sure many of you are doing something similar or have heard of someone doing something similar. I'm hoping that today we can learn something from each other. Our surgeons approached us in May of 2013 with a desire to find a more streamlined method for minimally invasive cases. We were doing almost 900 hearts a year in 2 ORs. To say efficiency is important is an understatement. They wanted to try single dosing, and as perfusionists, we felt it was our job to do the research. We were excited for the opportunity to find a method appropriate for adults. We also knew that to make this happen, we had to focus on the very thing that drives change: surgeon quality of life. This is a direct quote from one of our surgeons. Not being at all dramatic, as they are not, he told us that this new method provides better surgeon quality of life. In other words, he could operate with minimal interruption and a clear field. This is always a win in a perfusionist book. With our previous technique, we found ourselves with a suboptimal arrest, frequent interruptions, and multiple defibrillations. We followed a traditional dosing protocol of antegrade, followed by retrograde, redosing every 20 minutes, sometimes continuously. We were giving microplegia through the Quest MPS, but that was truly the only thing we were really happy with. Frustrated by this protocol, we began our research with Nido. We all know Nido was originally a pediatric solution developed in the 1990s, but is also being used for adults. It uses a single dose technique that delivers a weight-based induction dose of 20 mils per kilogram. It's delivered at a 1-part blood to 4-part crystalloid ratio. With potassium as the rest agent, lidocaine lends its properties as an antiarrhythmic drug and sodium channel blocker. Given its half-life of 1.5 to 2 hours, it contributes to a sustained arrest. Magnesium sulfate acts as a natural calcium channel blocker to minimize accumulation of calcium in the myocardium. Mannitol is a free radical scavenger, and sodium bicarb is used as a buffer. We liked everything about the composition except the crystalloid. At the time, Del Nido was being used by our then sister hospital, and the feedback was positive. Good arrest, quick reanimation, but everyone was converting to 1-to-4 to do it, and they were using the same method. Initially, as you can imagine, we had many questions. Is it appropriate? Better yet, could we modify the method to be appropriate for the adult heart? Could we give it as an all-blood microplegia? And could we customize the method to accommodate each patient as an individual? Lastly, would we be able to expand it to all comers and standardize our practice? With these challenges in mind, what started out as a goal for more efficiency evolved into what we call the KBC method. Why a new name? We knew that the minute we made any variation to Del Nido that it was no longer Del Nido. It was our goal to distinguish this method also from a pediatric single-dose approach. We were already Quest users, as I said, so our first attempt at single dosing was giving Del Nido in its traditional form through the MPS. As a brief review of the Quest system, it incorporates a main blood delivery system and 2 separate additive and arrest cassettes, giving unmatched flexibility and variability. In the picture on the right, you can see the arrest agent cassette in yellow and the additive cassette in green. Each is filled by the user. The yellow cassette is intended for potassium chloride at 2 milliequivalents per mil, while the additive cassette is filled by the user's selection of cardioprotective drugs. Having independent control of each cassette enables the user to accommodate individual patient needs at the simple touch of a button. Potassium level can be controlled independent of your additives. That will come into play later. Gone are the days of just a high and just a low dose. Here are the days of specialized, patient-specific dosing. The MPS can also adapt along with the ever-changing landscape of cardioplegia formulas. All that's needed is the turn of a dial. The flexibility of this machine is optimal to customization of any solution. When delivering traditional Del Nido with the MPS, typically the additive and arrest agents are not utilized, and the settings are 0 for both. We challenged ourselves to find a way to turn the 1-to-4 setting back to blood. After all, it had been there for us for almost 10 years. Had to use a little WD-40 to get it to go to that 1-to-4. The benefits of blood are well documented. Blood decreases hemodilution, maximizes oxygen carrying capacity, is a natural buffer, and has been shown to reduce myocardial edema. Why give crystalloid if we can give the patient their own blood? In this day and age of miniaturized circuits, retrograde autologous priming, and endless efforts to minimize hemodilution, it felt like a step backward to us. With blood as the carrier, we no longer needed a buffer, so we eliminated the bicarb. This method still utilizes potassium, lidocaine, magnesium sulfate, and mannitol for all of the same properties it lends to Del Nido. The 3 additive components come to us in a 60 cc syringe mixed up in-house by the pharmacy. It contains 32 mils of 20% mannitol, 8 mils of 50% mag, 13 mils of 2% lidocaine, totaling 53 mils in the syringe. This single syringe is all that's needed for the majority of our cases. The syringe is refrigerated and expires after 7 days. Now that we had the solution, how can we single dose safely in adults? The answer was, we customize, and we treat each patient as an individual. To accomplish this, we would need to do something even more difficult. We would have to change. We would have to change the way we think about cardioplegia, specifically dosing. We would have to abandon the one-size-fits-all mentality. We were used to frequent dosing. Now we're being asked to give a dose and wait. This was challenging for us frequent dosers, but we found a method that works for us, our surgeons, and our patients. This method utilizes a 3-part strategy. In addition to the induction dose, it offers a dosing assessment and a warm reanimation dose. The induction dose is weight-based at 15 mils per kilogram. It's delivered cold with a minimum of 1 liter and a maximum of 1,500. Both the additive and arrest setting are 21. A 1 liter dose at these settings delivers approximately 2.5 grams of mannitol, 1.6 grams of mag, and 100 milligrams of lidocaine, 21 milliequivalents of potassium as well. And the dosing assessment works like this. It begins with the induction dose. Most often, there will be no activity for 60 minutes. In this case, the perfusionist alerts the surgeon of the ischemic time. If there is an adequate arrest after the induction dose, we will evaluate the delivery method and redose per surgeon. At the 60-minute assessment, if there is sustained activity, we will evaluate 2 things: the patient potassium level and the estimated remaining arrest time. Because this is a long arresting type cardioplegia, giving a full dose is assumed to re-arrest the heart for upwards of an hour. Here is where the flexibility of the MPS becomes integral. If the estimated remaining arrest time is under an hour, we have the option to vary the additive concentration. The setting can be reduced if desired. The patient's potassium level determines what the arrest setting will be. At our institution, if it's above 5.5, we will give the next dose without any potassium. The assessment is important for a couple of reasons. First and foremost, it provides accountability to our patients. Second, it creates dialogue and opens the lines of communication between perfusionist and surgeon, placing the perfusionist in an integral role. Keep in mind, we are only redosing about 25% of the time. Another assessment is done at 60 minutes or with premature activity, and with every assessment, we evaluate and redose at the surgeon's discretion. The last step is the reanimation dose. Our previous protocol called for warm blood just prior to cross-clamp removal. We also bolus 200 milligrams of lidocaine and 2.5 grams of mag into the pump with this warm dose. So it was a natural transition for us to incorporate a warm reanimation dose into our method. Historically, the concept of reperfusion started in the 1970s, with the effects of terminal warm blood cardioplegia being first reported in 1986. An article published in 2012 by Dr. Ichikawa outlines the benefits of terminal warm blood. The mechanisms include restoring energy supply, in turn, decreasing energy consumption. Additional benefits include possible preservation of cyclic AMP, minimizing endothelial dysfunction in the coronary arteries, and controlling free radicals during reperfusion. The reanimation dose consists of 400 mils, given antegrade at a temperature of about 33 to 36 degrees. There is no potassium in the reanimation dose, but the combination of lidocaine, magnesium sulfate, and mannitol at varying settings is used to stabilize the heart before cross-clamp removal. To help paint the picture of what this looks like in practice, I have 3 case scenarios. The first is reflective of what we see most often. Most of the time, we see a good solid arrest and no redoses needed. This patient was a 71-year-old female in for a minimally invasive MVR. She weighed 68 kilos. At 15 mils per kilo, her induction dose was the minimum of 1 liter. We went on bypass and began cooling. The patient was cross-clamped and the induction dose was given. Very often, we can anticipate the duration and quality of arrest based on the volume it takes to achieve the initial arrest. In this patient, we saw an arrest 300 mils into giving the dose. There was no activity noted during the first 60 minutes after cross-clamp placement. During the dosing assessment, we simply notified the surgeon of ischemic time and noted that he was well into tying down the valve. No redose was needed. While the surgeon was closing the aorta, we prepared the warm dose by changing the temperature on the MPS and turning the potassium to 0. A reanimation dose of 400 mils was given and the cross-clamp removed. Heart recovered well and there was no defibrillation needed. Cross-clamp time was 59 minutes. The next patient was a 50-year-old male with severe AI in for an AVR. He weighed 80 kilograms with an induction dose of 1,200. We went on bypass, began cooling, and cross-clamped. The induction dose was delivered, assuring an adequate root pressure. We target a root pressure of about 200 to 250 millimeters of mercury to assure optimal distribution. This reflects back onto the MPS, taking into consideration the pressure drop between the heart and the machine at about a system pressure of 250 to 300. This patient took a little longer to arrest at about 900 mils into the dose. Shortly after the dose was in, activity resumed. Because the patient had severe AI, we decided to give an osteal dose down both coronary arteries. 300 mils were given at high concentration and a good arrest was achieved. No activity was seen at the 60-minute assessment, at which time the surgeon was seating the valve. We prepared and delivered the reanimation dose and took off the cross-clamp. Clamp time was 62 minutes. The last case is an example of a longer, more complex operation. This patient was a 65-year-old female with moderate to severe AI, mitral insufficiency, and coronary disease. She needed an AVR in addition to a redo mitral valve and CABG times 3. Her induction dose was 1,500 mils, and she took approximately 1 liter before we saw an arrest. The surgeon began sewing distals, at which time we began seeing sustained activity. After completing the first distal, we decided to give an osteal dose of 300 mils. This dose resulted in a good arrest and no additional doses were needed. There was no activity at the 60-minute assessment as well as the next 60-minute assessment. Reanimation was given and the cross-clamp removed. Patient recovered well with a 146-minute cross-clamp time. A couple of things to keep in mind. A good initial arrest will minimize any need for variation thereafter. This means assuring good distribution with the addition of an osteal or retrograde catheter, for example. Point number 2 is minimizing doses delivered within an hour of cross-clamp removal allows for a quicker, more natural reanimation. What began as a solution to increasing efficiency became a desired method for all cardiac patients. Our surgeons began using it for all comers. We use this protocol for valves, aortic cases, circulatory arrest cases, CABGs, and all emergencies. In full disclosure, most of our CABGs are done warm, beating, or off pump. We have more recent experience after hiring a new surgeon who prefers to cross-clamp his CABGs. In this situation, we give the usual induction dose, then run a low setting dose down the veins to test flow. We have a substantial number of combined CABG valve patients, and this has given us much of our experience with this method. where we lack in isolated cross-clamp CABGs we make up for here. We started delivering this protocol in the summer of 2013. 3 years and over 1,300 cardiac patients later, we have learned that at least at our center, single dosing is the new black, and we think it's here to stay. Amidst all of this, we wanted to know how we were doing. We did a retrospective analysis in 2015. It included a total of almost 1,400 patients, half of which received traditional blood microplegia given continuously or every 20 minutes. The other half received KBC, the KBC all-blood microplegia strategy. Our goal was to prove non-inferiority to our previous strategy. The first column here lists the categories. The second shows categories where KBC proved inferior. The third shows where we saw improvement with this method. KBC proved inferior for post-op strokes in AVR CABGs as well as post-op AFib in AVRs. These are the two groups to which we were unable to take into consideration the risk associated with our structural heart clinic. Where it says none, the group did not test inferior or superior. Essentially, there was no change. KBC demonstrated in many categories significant improvement, as you can see here. Where it is inherent to have a decrease in bypass and cross-clamp times when you are giving fewer doses of cardioplegia, use of the core knot system around the same time also contributes to this decrease in cross-clamp and bypass times. The retrospective nature of this review was very limiting. Also, we were unable to run several comparisons in many categories due to lack of data. The biggest limitation for this data set is that it's not risk adjusted. Of note, we began our structural heart clinic in February of 2012. This group of high-risk patients are referred directly into our AVR CABG categories. Observationally, we've seen a 50% reduction in potassium use, fewer defibrillations, less pacing leaving the OR, more fluid surgery, and as a result, cost savings. One of the things we all have in common as perfusionists is the great responsibility of arresting and protecting the hearts of our patients. It's one of the most important things we do. Yet, it's the least standardized. Around the time we finished developing our methodology, federal law passed the DQSA law. With the new stricter guidelines, CAPS decreased their available number of cardioplegia solutions from over 900 down to 43. Does that not shock anybody else? What does this tell us? We still have a long way to go. This protocol has helped our center to achieve a level of standardization that we never had before. That's not to say we're giving identical doses to all patients, but that we are customizing our doses, utilizing the same formula of drugs. What's the difference? We've gained a tremendous amount of experience in dosing. We understand the nuances because it's the only formula we give. We are in the driver's seat and being asked by our surgeons to help guide. This combination of drugs in collaboration with the technology of the MPS has opened us up to an entirely new world of cardioplegia. So are we protecting the heart? This is a question we ask every time we cross-clamp. This method is no different. Regardless of the formula or the method, it is up to us as clinicians to continue to evaluate each case and each patient individually. Just as we vary flow to accommodate BSA, customizing cardioplegia is ideal. Where do we go from here? I would love nothing more than to have some risk-adjusted data to present next year. A study with broadened parameters is long overdue. With that said, it has been demonstrated that an all-blood modified single-dose strategy can yield a sustained arrest with less overall potassium use and fewer surgical interruptions, thereby providing a more fluid surgery. I can make your heart stop and start again. Now, I realize these are lyrics to a song and probably referring to being in love. But when I saw it, I said, that's what I do. That's my job. So thank you for your attention.
Thank you, Candice. That's very good. I just, what I want to show is, when you say a liter and when you say you're given an extra dose, remember, it's only given 53 ml, less than 53 mLs of fluid. So it's really, you're not giving, it's blood. You're only giving 53 mLs of fluid to these patients. I guess if I look at it retrospectively and you looked at your data, from a blood management side, go back and see where you were as far as, your crits coming off bypass on your weight-based adjustment, and then...
I would love to, let me stop you, but I would love to have that comparison, but we've been all blood users throughout.
Yeah.
So at our center, we couldn't pull that data.
As far as the use of blood
Right.
at your centers. Yeah, I'm trying to get Cooper to basically get the tag in there.
It's coming. It's coming next month.
I know. The other thing too is to look at your, did you look at your spontaneous versus non-spontaneous cardioversions during that period of time? Because when I was there, pretty much all these patients just, boom, you didn't have to cardiovert hardly any of the patients there.
We didn't have a data set from our previous protocol. We are defibrillating about 10% of the KBC patients. There were some big gaps in data we found when we tried to look back, so I don't have anything other than that.
And I guess one of the third things is, what was I going to ask? It'll come back to me in a second, so let me think about it for a second. Have any? Yeah, I'm having one of my senior moments, yes. Ryan, do you have any questions? Okay.
Oh, I have a question.
Yeah.
Looking at this formula, it really is pretty basic,
Simple.
It's basic.
Why does this work? Is it a scenario where, we could do this really with any cardioplegia, or is there something special here
I think the lidocaine
that I'm missing?
the key to the sustained arrest, if that's what you're referring to. Could we just dose every 60 minutes with any cardioplegia? I don't think so. I think it would have to contain lidocaine.
I think and also, just talking to you and your other colleagues, pretty much, y'all are saying, we could make this even better because you're not sure that we even need this much potassium. And it's so nice that, the syringes are already there. They come up and pretty much put it in the pouch and you're done.
It's good to go. It's very
you're
simple.
Ready to go. It's so simple.
And we
And
continue.
you don't have to have a bag hanging there and you have to hook up the other spike or anything else. So it's just so straightforward. It's just so refreshing.
It is. Thank you. We continue to develop our method. We're working on a cross-clamped CABG-specific method, as well as a shorter cross-clamp method.
And pretty much most of the time, y'all do not use retrograde.
We rarely do.
Very rare. Y'all almost all antegrade
Yes.
and coronary going down the corner.